Ma'am, you are in live.
Okay. A very good evening. We'll look into the age factor soon. A very good evening to one and all of you for our eye educational webinar. And this time it's going to be challenging cataract scenarios with the young surgeons of our country. And believe me, friends, stay glued on because there's going to be a variety of cases which each of these talented guys have to show. We are truly lucky to have with us on the expert panel Dr. Ramurthy, whom we all know is the past president of All India Ophthalmic Society and is also the chairman of the Eye Foundation Group of Hospitals. We are very lucky to have with us Dr. Shrish Kumar, who is like a massive pillar of support for us, our medical superintendent and senior consultant, cornea, refractive and cataract services. There is hardly a case which he cannot deal. Joining us soon is going to be Dr. Nitin Balakrishnan. Would you, Velmugan, do please call him and check why he has not joined in? Is Dr. Balakrishnan, who practices at
he has sent a message. He'll be joining only at 7 o'clock, it seems. Yeah.
Oh, okay. I didn't see that. Okay. Who practices at Sai Deep Eye Clinic and Crystal Vision Laser Center at Santa Cruz East, Mumbai. And again, another very dynamic, versatile surgeon from Mumbai. And we have with us, we're truly lucky to have with us Dr. Sandeep Nagwekar, who I hold with a very great respect because he's not just an eye surgeon, he's a man with very intuitive intelligence where ophthalmology and the surgical pearls are concerned. And I'm sure he's going to teach us a lot. And he's a senior eye consultant at Lilavati Hospital and Research Center and Eye Clinic at Mumbai. And some of us were lucky to see his huge place. I haven't yet. And we are lucky to have with us a very dynamic Shail Vasavara. There's hardly a conference I miss nowadays, but there's hardly a conference which Shail misses. So I don't know which post he's going to contest for. But then having him in each of these meetings is a true pleasure because there's something so interesting and good he has to show to us at each of these meetings. We are lucky to have with us. Dr. Nivian Madhivanan. Again, another very dynamic, very innovative, versatile surgeon who's the academic director and vitreoretinal and cataract surgeon from MN Group of Eye Hospitals based at Chennai. Moderating along with me is Dr. Tamil Arasi. She definitely shouldn't need an introduction. You know, she's an amazing senior consultant of ours in the cataract and IOL services and a surgical trainer for all those surgeons who come to us. And probably she knows something much more than each of us think we do in our Eye Foundation Group of Hospitals. And that's what this very demure woman is. We start off with our first speaker, Dr. Nilesh Kumar, who's a medical director and consultant phaco-refractive glaucoma and medical retina from Madhvi Netralaya, Bihar. And again, he leads the YOC team with his dynamism. And let us see what his video has to teach us. Hello, Dr. Anujit.
Thank you so much, ma'am. I'll just share my screen.
Hello, I'm Dr. Nilesh Kumar and today I'm going to discuss my case, which I thought that it is a routine case. There is no hiccup during the capsular access. Gentle hydrodissection was done, and once I start doing the cortical shaving and now doing the primary chop, the first chop, I noticed that the bag is a little bit loose, and then when I try to grab it again, as you can see, the entire bag is shaking. Now I asked the patient, was there a trauma history, which I had asked in the clinic also, and he had said no, there is no trauma history, and now on table is saying that yes, a blunt trauma had happened a long time back. So now what to do? It is a loose bag and it's a rock hard nucleus. It is touching around grade 4. So now no other option, I had to switch to capsular hook for maintaining the capsular integrity and reducing the capsular tension. So I am using 2 capsular hooks from the area where I thought the deficiency is highest. So now tightening it, and now again. So now the strategy switches. I don't have to do anything that put pressure on the zonules. So now what I am doing is grabbing the nucleus, lifting it chopping it and then eating it in small pieces. And whenever I am doing it, whenever I take the phaco probe out, I just put some amount of viscoelastic so there is not much of vitreous prolapse happening from the loose zonular area. So again, as you see, lift it, chop it and eat it in small pieces. I'm not trying to like divide it into 8 pieces first and then start emulsification. And during rotation also, I have to be gentle, fill the visco, do it under the viscoelastic so that it rotates very easily. So now you see, with this maneuver, the video is playing at around 4 times the speed of what I had done. And you see the entire nucleus is out. Now the epinuclear plate is being cleaned up, so that is done. And now I'm placing the CTR. There is some amount of cortex there that is there, but I thought if I grab hold of the capsule while cleaning the cortex, the ZD might increase. So first put the capsular ring with the BX forceps. It's a very efficient technique when you use BX forceps and put it goes directly into the bag without any much manipulation. And now I am putting a single piece hydrophobic IOL in the bag, doing that before I take out the capsular hook. Some amount of cortical cleaning also will be done before the hooks are taken out, but not too much, even if little bit of cortex is there and it results in post-op capsular opacification, doesn't matter, we can do YAG later. So now, as you see, we are removing the capsular hook, and what I did is not to pull it out but to pull through the main wound using BX forceps so that there is least amount of trauma. And after that, some pilocar, and now I am staining with tricot and doing a minimal vitrectomy of a little bit of vitreous prolapse that has happened in the AC through the main wound. And post that, we'll just close the case. And as you can see, after doing vitrectomy, what I do is I keep the irrigation on, and during the irrigation on, I do the hydro so that the AC doesn't prolapse while we do hydro. Now I'll remove the side port after putting air bubbles. So one side port is now hydrated, and that's case done. Thank you.
Thank
Oh,
you so
that
much
was
for this opportunity.
that was a wonderful video, Nilesh. You had so many simple, intricate tips for us in that nice video of yours. So shall I start with Dr. Sandeep? Now, what would you say that, when we say we notice, especially these traumatic cases, you notice a dialysis, do you think we could have picked it up right at the stage of making the rexes? Or is it only when during the chopping technique, actually the dialysis unfolds itself?
See, if the dialysis has been there pre-operatively, then even during the rexes, you can make out by the resistance that you feel, the inability to complete the rexes in that particular, because there is no tractional force. You need some counteracting force by the zonules to enable you to do a rexes smoothly. So yes, one could also make out at that stage whether it has happened. Yes, one can.
And
maybe there is no vitreous there, but if the zonular traction is lost, the rex is not so easy to make.
Yes, yes. So would you then think that you start the rexes and sometimes you could give counter traction at that point itself with capsular hook and then
Yes.
if it were more subluxated than what this was?
There are different ways which have been done. In fact, I remember one video shown by Dr. Saurabh Patwardhan where he had actually introduced capsule forceps from the other end to actually hold and make a kind of a thing. So if you're not getting counter traction, there are other ways in which one can do it. Yes.
Yes.
Yeah, definitely.
Yeah. And Shail, I would ask you this. Now, the number of capsular hooks, like it felt sensible for him, that area of zonular weakness, which was so obvious, he decided to support it there. Do you feel that would be the way to go, or would you like to make it symmetric and give it an overall, because you never know which other zonule would give way in our manipulation of the surgery? What do you say?
Yeah, I think, ma'am, first of all, excellent management of the entire case. I would agree with you that I would generally, whenever I find, even if it is a sectoral, which normally it is a sectoral in such dense black brunescent cataracts which have had past history of trauma or otherwise, I would like to hook up the bag in all four directions, so that quite often you do need, in spite of whatever we may not want to do, we do need a lot of lateral separation forces to separate these fragments. And therefore, I would generally like to hook it up on all four quadrants. I think another important tip which he showed correctly is repeated injections of dispersive viscoelastic. The only suggestion that I would have for him would be that before withdrawing the probe, it will be better to inject it before withdrawing it rather than withdrawing it and then injecting it. If we can avoid any, forward bulge of the zonular complex, the chances of vitreous prolapse reduces. So something that Dr. Bob Usher has taught us for decades, the closed chamber technique. And third, probably a thing which I've learned actually the hard way is the size of the CTR. Because very often, particularly if you're working in an institute, you say a CTR and the CTR is given and you put in the CTR, but one must know that CTR come in different sizes. So 11 mm, 12 mm, 14 mm, 13 mm, so many different sizes. So it's important that if you are operating an adult, you use a large size CTR, so that you end up covering, or in fact over covering, the entire capsular bag rather than under covering it, because that can also make a difference. And the last point is that if there is cortex and if you're injecting a CTR, if you can't see visibly well, and if you're not sure whether it's going perfectly or not, the simplest trick that I've learned is to just thread one of the eyelets with a 10-0 nylon, so that in case you have to retrieve the CTR, you can pull it out with the suture itself.
Actually, the size of the CTR is also related to the axial length. And truly, if you're going
And
to
the white
ask for a
side,
CTR,
absolutely.
yeah, and the size of the capsular bag. So, these are very relevant. And since many of us, our friends are watching it, I think we should also ensure that when you dial in the CTR, the eyelids are away from the area of the zonular weakness. It's the long arm of the CTR, which is there in that area of zonular weakness. Before Tamil takes on the next question, does Dr. Ramurthy have anything to add, or Nivian, in this discussion this far?
Very nice presentation and very relevant comments. Just a couple of quick points. One is that Nilesh got a nice job at around the 6 o'clock meridian, and he did say that he minimized the manipulation to the extent possible. What I would have done is, even in the subincisional area, just created a trench and then split the nucleus into two, and then brought out the nucleus fragments into the anterior chamber using adequate amounts of dispersive viscoelastic, done the phacoemulsification essentially in the anterior chamber. So once you get the nucleus fragments out, the stress on the capsular bag is a little less. Of course, whatever he did, it worked quite well for him. But it just made into two heavy nuclei. And just adding on a point to what Shail already mentioned, apart from the sizing, some of these CTR comes with a large gap also. It's not a complete circle, but there is a large gap. And sometimes when you introduce it, later you find that there's an area where there's not a complete circumferential support. So I specifically make sure that, we get around 13 millimeter CTR. And then the two eyelets are almost abutting each other. It's a complete circle. That way you get a 360-degree support.
Talking of CTR, has anybody used that Henderson CTR, which
We ourselves have used it. Once upon a time, it used to be available from Aurolab, and we have used that and with the undulations.
Yeah, which allows you to remove the cortex with greater ease than otherwise. And yes, Tamil, could you take on about the cortex stripping and other things? Yeah.
Yes, ma'am. Excellent video, Dr. Nilesh. I just want to know from Dr. Sandeep, sir. Usually we say whenever there is a capsular bag compromise, we do a slow motion phacoemulsification. Do you change your phaco parameters when you notice a zonular weakness, or how do you do it?
You have to unmute yourself.
Unmute yourself.
I think I'm unmuted.
Yeah, now it's okay. Yeah.
Right. Yes, so automatically things tend to slow down. You just can't use the vacuums that you would normally use for that. I use the Centurion phaco machine, so I make sure that my IOP is kept at around 30 millimeters of mercury. I try not to use a vacuum more than 400 or 450, and my flow rate is around 30-32 in such kind of patients.
And we have seen few videos where the surgeons are using iris hooks instead of capsular hooks.
Yes.
Your comments on that, sir, Dr. Sandeep, sir?
Yeah, iris hooks can also be used in case capsular hooks are not available. Of course, but they don't give the stability that the capsular hooks brings to the capsular bag. So here you are trying to stabilize the bag and you're not sure about the zonular. As you know, as you saw in that case with that black cataract, we could hardly make out the extent of the zonular dialysis. Of course, he put it in the area where he was sure that there was zonular dialysis, but sometimes it may be more. So as was commented earlier, I would probably try to stabilize the bag a little more. That makes the thing a little safer because if your bag is not well supported in that plane, the zonular dialysis may actually increase during surgery. So you have to be a little careful on that front, is what I'd say. Yeah. But yes, as to answer your question, if in case just capsular bags are not available and iris hooks are, then you can use that. Yes.
So, Tamil, I think you want to add, yes, anything?
No, like this iris hooks and capsular hooks. I just want to add one point. Iris, of course, if you don't have a capsular hook, you can use iris hooks, but these iris hooks can cause damage to the anterior capsular rim, and it won't support the equator
No,
here.
it can't.
It can't.
Yeah, it won't
Correct.
support, and the gap between the anterior capsule and posterior capsule is also not maintained with the iris hook. So, if at all the capsular hooks is available, definitely we should go ahead with the capsular hooks.
Actually,
Yeah.
only if there is capsular hooks can you delay placing a CTR. If you are actually having iris hooks, then you should place a CTR earlier on because you want the equator of the capsular bag to be supported.
Can I just one last point I'll make over
Yeah.
here? The
Yeah.
moment you notice a zonular dialysis on the table, one additional thing that I do is put in a little bit of triamcinolone because you never know when the vitreous has presented. Very often in these black cataracts, you don't realize it has presented. But if you put triamcinolone acetate, you can make out that it has presented. You can do a little vitrectomy, and that supports the bag a little better as compared to that. So rather than using it at the end, you can use it even in the front.
So we go on to our second speaker, and even I would be taking questions from you first in that session, and you and Shrish before the rest. So we go on to our second speaker. Nilesh, hats off to you for starting the whole thing so beautifully.
Thank you, ma'am.
We have now next Dr. Karan Bhatia, who's a senior eye surgeon, super specialized in advanced premium cataract surgery, corneal disease, infection, dry eye, keratoconus, and refractive surgery and glaucoma management. Oh, Karan is doing it all. So, and of course, I have known Karan for some time, and he's one guy who can be so innovative in his skill sets. So, on to you, Karan, with your video.
Thank you, ma'am. I'll share my screen. So, is my screen visible?
Yes, a little blurred. It's okay.
This is actually the starting slide. That's why.
Yeah.
Okay.
Yeah.
This is a white eye and unexpected tail. So this is an 8-year-old, total cataract left eye, no history of intraocular surgery, no history of trauma. As you can see, the looks like a routine case. The capsule was stained with trypan blue and then washed with BSS, and then HPMC was used as an OVD. A clear corneal incision was made, and continuous curvilinear capsular excess was done. I prefer mine to do with the 26 case needed. So it looks like an easy case. And hydro maneuvers were done. Soften it out. But ideally, I would like to do it, from the main port only. Here I wanted to loosen it more. I put some OVD inside the eye. And let us first rewind and see what happened in slow motion. As I'm doing the hydro maneuvers, you can see that there's a black spot there. Something isn't right. And you can see this black spot is, again, it looked a little bit bigger. So in such a situation, you must slow down And you should suspect that there is something which you did not see, which was a pre-existing PCR. So in here, you have to change the strategy. So here, I would do a visco-assisted cortex aspiration. An alternate thing could be you could use a vitrectomy cutter in IA cut mode. So just aspirating it, and every time you see that there's something, you don't let the chamber collapse. There wasn't any vitreous disturbance. So then I shifted to the bimanual IA to make things a little bit faster. As you can see, there's a fibrosed rim with the PCR in the center, and some of the cortex has dropped back. So this is not going to give vision. I can put an IOL, but it's not going to give good vision. So the PC rim was cut, and using a micro-access forceps, a PPC was attempted. Lots of fibrosis was there. So this is again and again cut with micro scissors. You can also get a tag and use a vitrectomy cutter. The cutter wasn't effective. So here I implanted a 3-piece foldable lens into the bag. The good point is that I don't have to do another PPC again. The trick over here is that you should slow down, reassess, and then go ahead. Now coming to the next day, there was some drop cortex. A VR opinion was taken, and the surgeon had advised that this should resolve by itself with medical management, and which it did. So this part of the haptic was in the sulcus, so this was later put into the bag. And you can see it is very well centered. The ports were sutured and the IOL was stable. Thank you so much.
That was again a very interesting video. Karan, how old was this patient?
8-year-old. ma'am.
Yeah. So, my very first question is, when you're you started off making the rexes, PCC, but you have cut also. When you have cut at a particular point, that means there's a discontinuity. It's not a complete PCC.
No, there was a complete rexus was there. You're talking about the posterior rexus, you're saying, no, ma'am?
Posterior rexus.
Yes, ma'am. Because it was fibrosed, so it was
Yeah.
not it was very difficult to get it through this. I tried with the cutter, but the cutter was not eating it. So then I shifted to the scissors approach.
Yeah. So in that situation, if it were a single piece, it very gently will unfold in a not too properly done PCC. But a 3-piece IOL has a tendency to it comes ejecting with the greater force. So it could have, only thing, it's a fibrous capsule. So the extension of the PCC also is less likely you escape. But I wouldn't have felt happy putting a 3-piece in a PC, which is not exactly a PCC, is what I want. I would have preferred to place a 3-piece IOL in the sulcus and do an optic capture in this particular situation. Nivian, you could start, though it is Shail's favorite area to discuss in detail. So, yes, Nivian, your
Yes,
thought?
ma'am. Yeah. I think first of all, I think it was a challenging case and Karan. So this was a unilateral cataract in an 8-year-old.
I don't
Hello?
remember that. I'm sorry. It's an old case, so I don't remember it's unilateral or bilateral. Yes, unilateral does point towards trauma if that's where you're going.
Yes.
But the patient, because I have a case record over here, but the second eye the record is missing. But the patient had denied that there's no history of trauma multiple times. Something like, Nilesh's
Okay.
case, but the patient had
Yeah.
admitted
So
there.
one thing that I realized is
Yes, Nivian, there's some network issue there. Your voice is coming breaks. We don't hear you at all. Nivian?
I think, sorry, my network was gone.
Yeah.
Now can you hear me, ma'am? Sorry.
Yes.
But
No, Nivian,
My
you
network.
have to change your network. Shell, would you want to
I
take on?
think two things, very nice case and lot of learnings from the case. I've operated a few like this, and the first learning that I would get is from the pre-operative evaluation. That generally, if any child or adult presents with a white cataract, I would like to look at the chamber depth and the convexity of the anterior capsule. So if I find that there's a wide cataract, but the chamber is very deep, and normally you have the anterior lens capsule convex, whatever the normal nucleus or a cataract, if you find that flat and there's a wide cataract, that's a very sure sign that there is some leakage occurring through the posterior capsule. The second clinical pearl to look for preoperatively in such eyes is something what we described way back in 2006 called as a sinking sign. So if you make a slit and you look at the flat anterior capsule and you find some gaps in between the capsule and the cortex, this liquefied cortex, that's also a sign of a pre-existing defect that is there. So once we know that there is a pre-existing, we are very suspicious of a pre-existing defect. We want to tackle that case accordingly, and therefore even I don't think even if you would have not done a hydrodissection, this existing tear would have been there. So the only thing that I would suggest in any white cataract, particularly in children, because in children in a unilateral white cataract it's very common to have a pre-existing defect, is to start bimanual IA from the fornices, so that you leave that central nucleus chunk covering the posterior capsular defect until quite late. Because if you remove that gape, hole can gape up. And like you correctly said, most of these are very liquefied cortical fibers. So, good strong oral steroids post-operatively do tend to help in resolving most of these residual fibers if they are left behind in the vitreous cavity. And I would also agree with madam that if any doubt of posterior capsule integrity or its strength, best is to capture these IOLs, particularly in children, because as they grow and in trauma, if there's more inflammation, more fibrosis, back shifting and contraction, ideal would be to just capture this IOL either with haptics in the sulcus, or if there is a good PCCC, then haptics in the back and capture through the posterior capsular axis.
Amin, can you take the next question with Dr. Nitin has also joined? You could include him.
Yes, ma'am. Dr. Nitin, sir, this case is a case of a pediatric cataract and we expect the capsule to be elastic, but I think Dr. Karan effectively managed even with the cystitome. He did a very good rhexis. So how would you approach a pediatric anterior capsule while during doing a rhexis?
The first and the foremost thing is to use, I'm sorry, I joined in late, so I have not seen the whole presentation. But as a general rule, I think it's very important to use good viscoelastics so that and keep injecting viscoelastic all through so that you pressurize the anterior chamber, you push the posterior capsule behind, push the anterior capsule behind while you're doing the rhexis. And I personally prefer to use a forceps in pediatric cases, but if you are proficient using a cystitome, it really doesn't matter. But personally, I would use a microrhexis forceps and see to it that the main incision is not made prior to the finishing the rhexis. So I would just make the side port, inject a good viscoelastic, maybe use high density viscoelastic, and then do the entire rhexis with a microrhexis forceps so that the chamber remains stable all through. And in case there is any leakage of viscoelastic, keep adding more. In case it's very difficult with the elastic capsule to do a big rhexis in one go, I would make a small rhexis initially and then extend it, then spiral it to a bigger rhexis, so that at least that way you get a complete rhexis. So these are some of the key points which I would keep in mind. Sorry, I cannot comment much about the case because I just saw the terminal part when the lens was being inserted.
If as far as the lens goes, if it was assuming a unilateral cataract and this possibility of amblyopia being there and all that, is already 8-year-old, maybe the cataract might not have been very dense, assuming that the amblyopia was not much. Dr. Ramamurthy and Dr. Sandeep, both of you could tell, what would be your choice of lens in these cases? Would it be a need of multifocal or a monofocal?
I think best is to go with an aspheric single piece intraocular lens. We have implanted some multifocal, especially in 8-year-olds, bilateral cataract, but if it's unilateral, I think I would go with this. Just got a couple of comments on the surgery per se, as Nitin mentioned. Excellent case, very nicely presented, Karan. And what I have to add is that, as far as choice of viscoelastic is concerned, initially I would have used a cohesive viscoelastic to get good capsular access. But once I saw that small opening, I would have been very particular about using a dispersive viscoelastic, because that's what is going to tampen on. And an UBM or an ASOCT would have shown you maybe that there is a pre-existent defect, though would have been better prepared for it rather than, of course, maybe the management would not have changed very much. But slightly differ in this concept of managing a drop cortex. There was a fairly large chunk, and as you mentioned, it would get resolved. But what I find nowadays is that patients get very impatient in the sense that black spots and inflammation, raise of intraocular pressure. So if you have access to a good vitreoretinal colleague, and they do this 25 gauge sutureless vitrectomy. Actually, when I face such a situation, I immediately shifted to my VR colleagues' table. They just do it. They take hardly 10 minutes, no suture, nothing, and it's as good as new. And I would always, in a situation like this, I'd also favor a 3-piece lens with an optic capture, because that sort of stabilizes the lens much better. Just a few points.
So Sandeep, just one word of yours and one comment from Shrish.
I absolutely agree with everything that has been said. Wonderful case, well consented. And what Dr. Ramurthy said is exactly what I emphasized regarding the choice of the lens. It has to be a 3-piece lens with an optic capture. As Shahil said, if it's in the bag, it should be this. If the lens has to be captured in the bag, the haptics are in the sulcus, or if the haptics are in the bag, and if there's a PCC, put the lens behind it. Yeah. But that will give long-term stability. The second thing is exactly, again, what I actually wanted to make out is that I think the cortex could have been dealt there itself. Though this will get absorbed, it takes a real long time, and you're never very sure about vitritis and secondary glaucoma that might keep up in the post-operative period. If you handle it there and then fine, we can take care of that. And in a big institute, of course, it can be done. And even if it can't, it's a small institute, this can be tackled the very next day if required, So the patient is completely clean. So don't leave any room for error, is my take.
Shrish?
Yeah, nice case, Karan. If there is as Dr. Ramurthy mentioned, ASOCT or UVM would have helped, and if at all there is a posterior capsular break, or if there is a rent, pre-existing rent, you would not have done a hydro procedure in this particular case. You would have just gone ahead and aspirated. Bilateral aspiration, bimanual aspiration would have been sufficient here. And it's a loose cortex only. There is hardly any nucleus or epinucleus. It's only a cortex. And this cortex would not have gone to the vitreous cavity. And again, regarding the posterior capsular rhexis, of course, he could not complete it. It is not a circular rhexis, but this is the capsular defect is fully fibrosed. Actually, a fibrosed defect usually won't enlarge. It won't go to the periphery. In such cases, like posterior capsular manipulation can be easily done. And if at all you wanted to place a lens in the bag, you can easily place these lenses. So, like multifocal or EDOF lens, it is a choice of the surgeon, but you can place the lens in the bag.
Which Karan has done very well. I just wanted to create a discussion thing, so that's why I brought it up. Nivian, the dropped cortex.
Sorry, ma'am. Yeah. So it was an excellent thing. The first thing is you recognized it very early, and even though it was just a small defect, so that I think saved you from losing the entire thing.
No,
as a rule, don't do any hydro through the side port. Sorry, ma'am?
No, I don't want comments on anything, just the dropped cortex of a retina man.
Yeah, so when you were using the cutter, you tried to cut the capsule, when you wanted to do the posterior capsular rhexis, you could have used the same cutter actually, because some amount of posterior hyaloid vitrectomy is also done in all these pediatric cataracts. So you just wait for some time there when you're doing with the cutter, those cortex tend to come up. And this is also a little the vitreous is slightly thicker in these young children. It's not thing. So it would have come actually. So when you know what to do, you could have removed the cortex that there itself.
Thank you very much.
It actually came. It
one other
actually
step.
came. With the cutter, it actually came. I did the same thing.
Yeah.
Some of it was left, which had gone down, but I do this a lot
Yeah.
with the face down of the cutter.
Yes.
One
Very
other step I would have just recommended is, all these situations always check with diluted triamcinolone acetate. At the end of the surgery, invariably you find some strands, and it's very easy to deal with it right then rather than looking at it and the slit lamp there on day one.
So we go on. Thank you, Karan. We go on to our next speaker, Dr. Aditya Sethi, who is from Arunodaya Deseret Eye Hospital as a pediatric ophthalmologist and a squint surgeon, and of course a neuro-ophthalmologist too. And it's a quite a great setup at Gurugram. And let's have his video. Again, another very major role player in the very dynamic YOSI organization.
Thank you so much, ma'am and sir, for having us here and showing all our challenges. I think it's so much fun to see everybody facing similar problems that we all do in our life. So this is one of the challenges that I faced. I like to divide it amongst three phases. So it's a very interesting story. So let's see if we can play it. Can we play?
Yes.
You have the volume a little low. So this is a 38-year-old male wrestler by profession. He came to my OPD with this sort of a cataract where you could see some zonular weakness. So just to avoid any sort of complication, what we did was a slow motion phaco. We dialed it into the AC, half of it, and then we did a slow motion phaco right there. And we implanted a CTR when we thought we were comfortable. Placed an IOL, and of course, he was doing very well post-op day one. We checked with triamcinolone as well. But since he was a wrestler, I knew this was not the end. The Balboa just started. 2 years later, he said he got another punch right on the same eye. And now you can see where the IOL bag complex is. And he said that he was definitely felt better when he was sleeping and everything was dangling. And that's when we decided to go ahead and surgically intervene because this would fall anytime. So we decided to make a corneoscleral tunnel. And once we did that, we decided to use our iris claw forceps after using iris hooks again because the trauma had made his iris muscles a little weak. And we decided to handle the entire iris bag complex because it was all dangling in one go with the iris claw forceps giving us very good coverage, and we ended up picking it up in one go and taking it out. And now we rendered him aphakic and we decided to do a nice vitrectomy. First thing with vitrectomies is make sure that you don't have any loose ends coming out of the eye. We took out the iris hooks as well. Once this part was done, we did a nice vitrectomy, making sure that there is no vitreous strands, anything left. So this gave a very nice first day sort of a look of eye. And we decided to implant in iris claw, much to Nivian's dismay. Would have preferred if we put a CMT flex, I'm sure. But we decided to put iris claw right there. Now, choice of an iris claw lens was made consciously, hoping that this would be the most stable for him. There was a lot of counseling done again with the patient that we can't keep taking you to the OR. You have to be careful with your profession, make the right choices, wear protective glasses, XYZ. And then we decided to implant the iris claw. And iris claw, you can see how stable that is. Not very worried about how it's going to be. And then he did pretty well the next day. But then again, as they say, the profession takes a punch. He took one again. And this is the time where he came with a dangling iris claw lens. And the iris was torn and half of it was coming out of the corneoscleral tunnel. And this was a situation where we had to sit down with him and really have a long drawn chat. We can't keep going in and doing surgeries again and again for you. And then we decided, okay, we're going to go ahead and de-shave the remaining part of the iris claw, which is a very tough situation to start with. And we implanted a Yamane IOL. And trust me, after all of these three things happening in the same person, he's given up on wrestling. He's more of a coach now. And that is the story of a cataract challenge that we faced in our practice. And hopefully, we turn out to be like Rocky, getting up every time and getting the best result out of that. Thank you so much.
Thank you. Thank you, Aditya. That was another very wonderful, challenging surgery, rather a stretch of surgeries. Tamil, would you want to take the first question? You could direct them to two of
Yes.
them. Yeah.
Now, since Nibian is here, I just want to ask is the second sitting, it was a single piece IOL with the CTR and the back subluxation. What would be your way of approaching that at that time?
So yeah, so whatever Aditya did was excellent because basically you have only two choices. One, because it was a single piece foldable, you can still try to elevate the entire IOL back complex up and then try to cut the IOL and then remove through the clear cornea. But that is if you're already prepared to keep a three-piece scleral fixated lens, either the Yamane or the Exnic, whatever technique that you use. But since you had already planned for a claw lens, I think the sclerocorneal approach is the best and the safest. As you said, the CTR is also there. So it's easier to remove because sometimes we lose the CTR. It is very, very difficult to retrieve the CTR
You can't
from the
get it back.
vitreous cavity. So as long as you take the entire complex, and I think the claw lens also was perfectly positioned and well enclaved. So the just is bad luck that had to dislocate again. But at least for the third time, you should have gone for the CMT flex.
True. Maybe the fourth.
Any one of you experts could answer this. A young patient, unilateral cataract, and okay, is a wrestler. He would have opted for the spectacle independence, no? So what would you have thought as the IOL of choice in this
Whichever
hypothesis?
doesn't fall, ma'am, in this case. We got knocked so many times that we wanted the IOL to stay.
No, Dr. Sandeep, Dr. Shell, Dr. Ramurthy, anybody?
I think, ma'am, the excellent management, Aditya, superb case. I think in the second and third surgery, I don't think the IOL type or power or is of concern. Our concern is of safety.
Yeah.
And I would, just recommend for beginners, Aditya did it wonderfully. But the second sitting surgery, removing the IOL, I would caution removing the entire IOL bag complex without doing a vitrectomy around the IOL bag complex, because there is usually vitreous entangled to it. And when we pull it out, it causes a lot of traction. And I know Aditya has Vaibhav to take care of the retinal detachment if it occurs. But the chances of giant retinal tears occurring are quite high. So I would strongly recommend that you must do you can grab the IOL bag complex with one forceps in one hand and do with the vitrector a vitrectomy all around the IOL bag complex before actually bringing it out and pulling it out in the anterior chamber. And then, of course, whatever the choice of IOL fixation, I think there is no perfect secondary IOL fixation technique. Each has its own, pros and cons. And in today's time, I mean, we have done the 0x quite a few times earlier, but now in today's time, I would not do this case, particularly the second or third time, without my VR colleague along with me in the OR. So I would have him do a complete vitrectomy, because they like Dr. Ramamurthy sir said, for them, they're doing a 3-port pars plana vitrectomy, which is a non-diabetic, is like doing cataract surgery for us. The outcomes are so good, and therefore the long-term outcomes, chances of cystoid macular edemas, retinal breaks, all of that are so good when they do it on table, a 3-port pars plana. They indent it, they look for breaks, and if they find it, they laser it, and so on. So I think from the long-term perspective, such complicated scenarios, I would strongly suggest that we work as a team.
Yes, 100%. Do you have anything to add before we go on to our next talk? Because I think
what Sahil said is what we follow for routinely, ma'am. Just one point to add, in that case, you need to have an AC maintainer. So what I seen in your case is, so if you have an AC maintainer or a trocar AC maintainer, then you can hold it with one hand and use the other hand for doing the vitrectomy around the IOL before pulling it out. Because hypotonia is another major challenge in these types of cases. So always go for an AC maintainer or a trocar.
Yes, I
Just for
think that
infusion.
that's the dictum that all VR surgeons have taught us, including Niven, that you must have fluid in the eye when you're doing vitrectomy. It cannot be a dry vitrectomy. Absolutely. Well taken.
Very nice points. Just one point regarding the iris enclavation as such. Aditya, you did say that you use pilocarpine, but still the pupil was reasonably mid-dilated. And very often, of course, if you get boxed in the eye, any lens can fall back. But otherwise, for getting a good enclavation, it also depends on the amount of tissue that's iris tissue that's enclavated. I find that if you really constricted the pupil well, we're able to maneuver the haptics behind and then cause that enclavation, there's a significantly more amount of iris tissue that gets caught, and that gives you a better stability. And sometimes I even like to see a little bit of horizontal ovalization of the iris, because that tells me that there is a little more of capture of the iris, and that gives a little stability as far as this posterior enclavated iris capture lenses are concerned.
Yes, all very valid
Thanks.
points. We shall go on to our, we're changing the arrangement a bit. Next is going to be Aditya because he had made the special request. And because Soumya's video is similar to his, Aditya will present his video. Soon, next would be Soumya presenting hers. And then we would together discuss the questions relevant to both their talks. So we have Aditya Varman, again, a very dynamic UOC leader, who's a cataract refractive surgeon from Uma Eye Clinic, Chennai, who is close on the footsteps of his father, being getting himself as versatile a cataract surgeon and a refractive surgeon. You are a pride to watch, Aditya. So let's have your video.
Shall I share my screen, ma'am, or are you playing from your side?
No, you share your screen if it's unless you want it played from you.
No, I'll do it, ma'am. No worries.
Yeah.
Okay.
Soumya, you be ready for the next. Is Soumya connected?
Yes, ma'am. I'm
Yeah.
here.
Yeah.
Okay. How do I go to full screen?
You're on full screen.
Yeah.
You're on full screen.
Okay, right. Yeah. So this case is a case of a black cataract with pseudo exfoliation. So I'm just going to start the case now. So we start by making a 2.8 millimeter clear corneal temporal incision. So what I'm doing for this case is I'm using a Kugelin hook and a Y instrument to stretch the pupil. So of course, you can take your choice of pupil expanders here. You can use iris hooks, so you can use a ring of your choice. But I find that when you're doing this pupil stretching, you're more efficient, you save time. And if your fluidics and your incisions are tight, you will not face any untoward iris complications or prolapse. So once I've done the stretching, I've injected some phenocaine and dispersed the viscoelastic. We start with the rexus. Ideally, the rexus now, you must overlap the margin of the pupil because this pupil is about 4 or 4.5 millimeters. So only once you overlap the pupil will you end up with a 5 or a 5.5 millimeter rexus. So of course, it's better to stain, but here I'm able to see the capsule quite well with the microscope. It's a lot better under the microscope than it looks in the video. So I'm able to make a 5.5 millimeter rexus here quite easily. And then once that's done, we start off with the phaco. So what I'm using here is a Centurion, and the tip is a little different. It's called a pentagon tip. It's a custom tip. It's got a large bore and it's got a narrower choke point. This is to enhance the followability and the holdability of the nucleus. What I'm doing here is a staged kind of trench where I'm making multiple levels of trenching. You've got one floor on the top, a second floor on the bottom, and a third floor right down deep into the endonucleus. So that's to ensure that the endonucleus core is quite well exposed so that you can chop quite easily. So I'm using a sharp, long chopper. So you embed very deep into the nuclear core and you crack by doing a vertical chop. Of course, in these cataracts, you will probably not get an end-to-end chop, but that's totally fine. As long as you're at least about 70 to 80% of the way through, that is okay. Do not be tempted to do too much lateral separation because you will very easily start to break the zonules. Rather than having a full end-to-end chop, what I am focusing right now is to get a sliver of the nuclear piece out of the bag. So once we at least free one sliver of the piece, a small portion, about 15 to 20% of it, then what ends up happening is you have enough space in the capsular bag to do a little more lateral separation and do a complete chop later on. So I'm still only directing all of my energy to get this small piece out, and then you emulsify it in the iris plane. So now once you've done that, you have a lot more space inside the capsular bag to finish all your maneuvers. And now you can do lateral separation to your heart's content because you're not stressing out the zonule so much. So what's important here is you just stay at the iris plane and you continue the phaco. Pay attention to the fluidics. In case there's any bounce in the chamber or if you feel the iris is coming close to your tip, it's better to lower the parameters. Here I'm using a vacuum of around 650, power of around 60 and a flow rate of 50. The ideal thing to do is to make smaller and smaller pieces of this cataract, and then you try to finish them in the iris plane itself. As you can see, the benefit of this tip where the fallibility is so good, and it's all concentrated at the tips. It's all concentrated around the tip only. You don't see that it pulls the iris inside. That's because of the design of the tip. And from that, in between, I have switched over to the balance tip now because I wanted to see the difference between the performance of these two different tips. But ideally, you just stay in the center, and if your fluidics are all right and your incisions are tight, you will not face iris prolapse, nor will you grab the iris at all as you're doing the phacoemulsification in the iris plane. So that's it. We're finishing up with the phaco right up to the last piece. And because there's very little cortex, you can even do the cortical aspiration later. We place the IOL in the bag, dial it inside, and we finish it up with INA. So ideally, what I wanted to describe here is that you don't need pupil expanders in all your cases. You can do well without the use of expanders. If your fluidics are good and your incisions are tight enough, you can manage very well in small pupil cases, even if the cataract is hard or zonules are loose. Thank you.
Oh, wonderful surgery, Aditya. Shall we take Soumya's surgery also, and then we could discuss both the things with equal consideration to the two good surgeons. Soumya is a consultant glaucoma, cataract, and refractive surgery from Trinity Hospital, Palghat. And shall we have your video, Soumya?
Ma'am, it's very raining over here. Can he play
Yes,
from there?
Yes, when Murugan will start.
Actually, my video is also on a small pupil phaco.
Velmurugan, you have to fast forward the video a little because I think the video is 7 minutes. We need 4-minute video only. You can stop the video now, Velmurugan. Two very challenging surgeries we saw of young surgeons. So now let me start off with the first question with Dr. Sandeep or Dr. Nitin. Is there?
Yeah.
Like, what would be your threshold for using pupil expansion devices? Would it be a really low threshold, or would you try to do what gymnastics these guys did?
So, there was an age when I used to do these things.
Hmm.
I think I'm getting old and senior now, so my threshold has gone down,
Nice.
especially with regard to the density of the cataract. See, both these cataracts were fairly dense.
Yeah.
And, when you're dealing with a dense cataract, it's always better to have as good a pupil as possible. Maybe not fully dilated, but much more than what she had in that. It makes the surgery long. It makes the surgery a little complicated. If things go wrong, then you are also in a mess. So I think I would use a pupillary expansion device in this. If it were a softer cataract, I might have managed the way she did, but I would probably not do that with that. I mean, one can always do and show, but I think in the long run, the law of averages suggests that you should use some pupillary expansion device. In the first case, the comment is that there was also pseudo exfoliation. So you have to be wary of the zonules in these cases. And so when you're going to be manipulating, you have to be extremely gentle in these patients because you can have zone dialysis on the table. But my threshold is going down.
Yes.
Maybe I'm getting old.
I think it's very, very important rather than, I mean, they're good. It's not that they could not have gone wrong in their principles, otherwise the surgery wouldn't have ended well. But this can go anyways. So I think the message is that we should use pupillary expansion devices at the very first moment, unless it's a soft cataract and not hard or not pseudo exfoliated, is one message. And the iris did tend to prolapse when you're doing hydro. In these small pupil, and when the iris tends to prolapse, then and if the iris is going to prolapse, would then your procedure vary, Dr. Nitin?
So the first and the foremost is with Dr. Soumya's case, I think, like Sandeep said, even I wouldn't attempt a case without a pupillary. It was a very well done surgery. Kudos to her. But then a few things which I would have tried is I would have tried using phenocaine intracameral. I would have tried a viscodilatation. And if that doesn't work, then at least I would have stretched the pupil. So and then decided whether I need to go ahead and use a pupillary manual pupillary dilatation device. The second thing is, while staining the anterior capsule, especially when you're doing the cases with these small pupils, it's very important that one doesn't inject a blob of the trypan blue into the chamber, but goes below the pupil, because very often when you are doing a rhexis, you may not see the peripheral part of the capsule because that part of the capsule is not stained. Again, if the rhexis is as small or it goes a little beyond the pupillary margin, then every time you have to aspirate the cortex, your phaco probe or your IA probe has to go below the iris. So it's a blind procedure. You may tend to hold the capsular rhexis margin. So these are things which are something which I think, especially when we are presenting this to the juniors, it should be reminded that this can be done, but at very experienced hands, like Dr. Soumya's. But like Sandeep said, even my threshold is very low, and I would definitely do the steps which I mentioned, and then decide whether I need to use a pupillary expander or no.
I think I would also like to, as he said, inject trypan blue beneath the pupil, extending further. And I would like to retract the pupil every now and then as I make my rhexis, so that I visualize where the rhexis is going rather than not retract it at all. And,
So we have customized an instrument which is called as a duoplater, which is basically a combination of a Y hook with a dialer with a Sinskey hook. So for these cases, I especially like that instrument for cases where the pupil goes down during surgery, and I maybe a last fragment. So I use the Y hook part of the same instrument to retract the iris, and then at the same time use the Sinskey part to chop the nucleus.
Dr. Ramurthy, your thoughts, and Tamil, can you take the next question?
Oh, I tend to agree with them. Both of them did excellent surgery, but I suppose, after using phenocane and viscomydriasis, if it's not big enough, especially with these hard cataracts, pseudo-exfoliation, and maybe history of taking triamcinolone, not triamcinolone, this anti-prostate drug.
Tamsulosin.
Yeah, tamsulosin. Then obviously your threshold for using some kind of a device to have a larger pupil is always good. Sometimes, I mean, I used to stretch the pupils quite a lot about a decade back. But once if you have stretched it and the pupil sphincter has lost its tone, if at all you tend to capture once you have caught with the phaco probe, there's always a constant tendency for the iris to flow into the phaco probe, making the surgery quite difficult. So I think it's, yes, it is doable, and both these surgeons did very well. But then I think it's better to be safe than sorry. And I always differentiate between a small pupil phacoemulsification and a small rhexis phacoemulsification. So even if the pupil is just about 4 millimeters, I run the rhexis under the pupillary margin and using that as a sort of a cutting board, getting about 4.5 or 5 millimeter. And I find that that again works reasonably well in my hands.
Yes, Tamil? You could direct the question to Shrish also, Shrish and Nivian.
Yes, ma'am. Excellent surgery by both the surgeons. I think both are very hard cataracts. I just want to ask Sirishma sir, like impaling the core and getting the first crack is always challenging. And what are your tips to achieve?
Yes, it's a nice surgeries. Both the cases very hard cataracts, and the first case actually the dilatation was okay, moderate dilatation, maybe around 5 millimeters dilatation, and the 5 millimeter dilatation, of course, the stretching I think has not helped him at all. Like the pupil remained the same throughout. And it is a rigid pupil. In any rigid pupil, we can like get away with it. We can do the phaco without much complications. And both the cases you can do phaco, but the first case it's a very hard cataract, grade 5 cataract. I usually do a multi-level chopping. I do a central trench and I go very deep, and then do the cracking, vertical chop and horizontal chop combination I do. And once you create a crack in this thing, and you rotate it and you make a small segment and remove it, and then you have more space, and then your cracking or lateral separation becomes easy. And the second case, it's just a 3.5 millimeter pupil. And in such cases, even though you are able to do a phaco, it's better to stretch the pupil, or you expand the pupil using a capsular hook or rings, because you are going to create only 3.5 millimeter rexes. It would definitely cause problem, while doing phaco also. If you catch the capsular margin, definitely there will be a tear and it will become difficult. And even pupil, this capsular phimosis can occur, and if you're implanting a toric lens, it becomes very difficult. So the second case, I would have gone ahead with the expansion ring.
Yeah. Yes, Tamil, anything else to add?
Yes, ma'am. Again, having an adequate phaco tip exposure is also really important for impaling, which both of them had in their case.
Yeah.
Any thoughts, Dr. Shail?
Shail, if it had been,
I agree.
IFIS had added on to this.
Yeah,
What
so I think that two issues. One is that the pupil being small is one part and being floppy is another part. So typically, most of the pseudo exfoliation pupils are usually not very floppy.
Yeah.
And they don't change much whatever you do. The second thing, in fact, I find it more difficult to do soft cataracts in a small pupil than hard cataracts, because hard cataracts, at least you can chop in the center and you can do that. Soft cataract, sometimes you end up even worse than a hard cataract. So I completely agree with Nagvekar sir and Dr. Ramamurthy that I would not hesitate to use iris hooks very early on, because if you use them gently enough, they generally don't cause too much of pupil distortion. And that pupil distortion is typically for us when we see on the slit lamp. It hardly ever causes too much of fixed dilatation of the pupil or anything post-operatively. So I think the take-home message for everyone would be that you can, all of us, if we train hard enough, we can achieve anything in any surgery. But I think there should be no hesitation or no ego in using expansion devices.
Just a small comment, I mean, in the sense that from the panelists, I think Soumya has used a Centurion machine. I also experienced this. In the subincisional area, she had some iris atrophy, frayed iris. And though she never really caught the iris during the surgery.
Yes, sir.
I also see sometimes when the pupil is somewhat small and I have to do deep trenching, that there is some amount of shafting of the iris. And this is, even I've been using the Centurion almost for a decade and I really like the machine. But this is one thing I don't know whether it's because of the balance tip design or whether it's the way the tip moves, that specifically with this machine, we have been finding this. Even though the case has gone on right through quite well, and I feel that I've never touched the iris. At the end of the surgery, I find that in the subluxation area, the iris.
Yeah. So thanks, two great surgeons with your wonderful surgeries. We go on to our next speaker, Dr. Rakshit Nathan, a young dynamic addition to our Eye Foundation group of hospital. He's a consultant cornea, cataract, and refractive services and has been doing amazing work since he's joined us. So on to you, Rakshit.
Good evening, everyone. Thank you for the opportunity. So this is a case of ICL explantation along with a cataract surgery, which turned out to be a little bit more complicated than expected. So just to give a bit of background, this was an ICL done elsewhere 12 years ago before she presented to us with this anti-subcapsular opacity. She had significant regression as well. She had a myopia of 30, she had an axial length of 32 millimeters. And this was the cataract, and this is the surgery. Let's see how it goes. So we initially start with the paracentesis and then put phenocane in. As you can see, the lens is moving around, which means it's of low volt, probably response with the cataract. And first thing I do is put the trypan blue underneath the ICL so I can get the staining done before OVD goes into the eye. And once this is done, I fill my antechamber with HPMC and make a 2.8 millimeter clear corneal incision. Once this is performed, I need to deal with the ICL first. And as I'm trying to get this into the AC, as you can see here when the video pauses, that there is the visible lens equator again telling me that there is severe generalized zonular weakness in this patient. Of course, before I can deal with the zonular weakness, I need to get the ICL out. And that's what I'm doing here with this micro-grasping forceps and the Sinski in my non-dominant hand. Getting some OVD above the ICL to protect the cornea. And with a hand-over-hand technique, which is not visible here, I'm using a McPherson in my other hand. It quite effortlessly comes out through the 2.8 millimeter incision. Now I initiate the capsular rexus, and it's quite apparent the whole lens bag complex is really moving around. But taking it slow and steady, I'm able to somehow achieve a reasonable sized capsular rexus in this particular case. And this is basically a very soft cataract. This is a 36-year-old lady. So I'm going ahead with hydrodissection followed by hydrodelineation. The nucleus epinuclear complex pops out partially from the bag. And I think, okay, let me try and rotate this and get it out of the bag entirely. But I'm not happy with the way the whole lens bag complex is moving. So I think let me try and debulk this a bit with my phaco probe aspiration alone, no power here. But this is also something that I'm not very comfortable with. And I decided that the best thing to do would be to support the capsular bag with these McColl style capsular retractors or capsule hooks. So I use 4 capsular retractors here, and these, like mentioned before, extend up to the equator and provide pretty good support of the bag fornices. And now effortlessly, this soft chunk of nucleus epinuclear complex really effortlessly flows into the phaco probe. Again, zero power being used here. It's just in the irrigation aspiration mode. And this is made very quick work of. And once this is dealt with, we can move on to the cortex aspiration. And this is done quadrant by quadrant, trying to be as tangential as possible. A few loose strands here picked up radially. And as we complete this, you can see a few spots of debris floating around, probably some of the matter that is leaked through the weak zonules. And here, one strand of cortex is entangled within this capsular retractor, which is also then removed. And now we can inflate the bag with OVD, and I decided to put the CTR in even before removing the capsular retractors. Probably should have gone for a larger size CTR, but this was the size we had. I think this is a 13 mm. For this very long axial length, probably needed the 14 size. This seemed to be quite small for this particular capsular bag. Nevertheless, once the hooks are out, it looks like the capsular rexus margin is pretty much how I made it. So I'm not seeing a gross displacement. So I go ahead and implant this Expand series 3-piece IOL, which is of 0 diopters, getting it into the anterior chamber first. And the first leading haptic seems to have gone into the bag. And I plan to do an optic capture with the lens and the sulcus. So I gently maneuver the leading haptic beneath the iris and then dial this again behind the iris. And once this is performed, I go ahead and first aspirate the OVD that is behind the IOL, followed by the OVD in front of the IOL, before then going ahead under irrigation and rotating the IOL to the desired position, and then gently tucking in these inferior and then the superior part of the optic, having a nice having a nice bag capture over here of the IOL, which I'm sure would make for long-term stability. The patient was thrilled, had 6.6 vision with a 0.75 cylinder, and she was very keen to get the other eye done, but I was not keen because the cataract was not significant enough, and we know the dangers of doing early cataract surgery in these very high modes. Thank you for your patient listening.
Oh, yes, Rakshit, that was a wonderful video which you showed. Because, I think you did not anticipate a zonular weakness in this patient when you started off. But if you look at it at hindsight, even if you had known, these are the exact steps which you would have done. It was a right thing to stain with Trypan blue before we inject viscoelastic. Whether it is these cases or the coloboma cases, it is very, very important that in coloboma cases, vice versa. So we stain it before and then we inject viscoelastic. That's one very important tip. The other excellent thing which is done is use capsular hooks, because so that there is the management and the bag remains stable, and he has done it. And the most important thing was that optic capture which he did. You could have, it was just made it so complete that we were well taken care of. The subluxation, though, was not a large subluxation. He has taken good care that it stays on that way for a long time. So yes, on to Dr. Sandeep. Would you want to add anything to it?
I think he was excellent. Absolutely fantastic. This little point about that Trypan blue staining of the anterior capsule, so very important. The way he took out the IOL, I wish he had shown that hand-hand technique a little more, but Yeah, it was good. And it comes out very easily. That's the best part about ICL as compared to the IPCL, which I have also explanted sometimes. And this step about keeping the lens in the sulcus and capturing it in the back, that was the best part about it all. One little point I'll add, Chitra, and very, very high myopes. I've seen these zonules being weak quite often. It's not unknown. How old was the patient, if I may ask, Rakshit?
This was a 36-year-old lady, sir.
Young patient. Okay. Yeah.
But then coming to another important thing, the phakic IOLs, while we are on it, which kind of, this was of course got cataractus and had to be handled, but how low a vault would you watch before you decide to implant? Because Ramurthy, would you want to answer that?
Oh, your question is how low a vault you would before deciding to explant?
Yes.
Yeah. So I think, classically it's at 250 to 750 microns, but we have quite a series of cases there where the vault has been lower than that. And if the anterior capsule is quite clear, no subcapsular fibrosis occurring, there's no need to rush into removing these lenses. Now that all these lenses, whether it's the Indian or the imported ones, come with a central flow, the chance of cataract is also less. So if the surgery has gone well, even if it's a low vault, we do follow up these cases with serial A's, OCT, and slit lamp examination, but then are never in a hurry to explant these lenses. This has also been borne out by a good study, what a meta-analysis done by Mark Becker, in which he has combined the study from multiple different authors and shown that the incidence of cataract is not directly related to walls, and even of 100, 120 microns can be followed up provided there is no cataract. This case also, there was hardly any anterior subcapsular fibrosis. Even the rexes came off quite well. High myopes, as we know, that have greater propensity for earlier nuclear sclerosis. So sometimes it's not just the lens which is responsible. But of course, dealing with the case remains the same, and it was very well dealt with. Only one point, Rakshit, I might have done differently is sometimes I find that if you bring the entire phakic lens in the anterior chamber, it becomes a little more difficult to handle. Just bringing one pad out and bringing it near the main incision and just holding it with the forceps and just then bringing it out gives you a little more control.
That was actually my original plan, was to actually do that. But the way the lens was wobbling when that happened, I didn't want to put excess stress on these zonules of the nasal side. And I thought, let me bring it to the AC and then deal with it so that I'm not disturbing the lens back complex as far as possible. Otherwise, I would have done the same thing that you said.
Yes. Yes, Dr. Nitin, you want to add anything before we? Dr. Nitin is not there.
No, it was a very well done surgery. It was one of the managed very, very well. So absolutely nothing more to add beyond what Dr. Ramurthy mentioned.
Yeah. Just one
question.
One thing I want to ask you, Shel.
Yes.
If you were to do flags for this, would you want to add something?
We have done flags with the ICL in place. I think Dr. Ramamurthy has also shown videos where rexes and lens nuclear division can be done. I've had one case where during manipulation of the ICL and bringing out the ICL, the one weak point in the capsular rexes had extended below the ICL. So, I think we can do flags along with the ICL. It's not something that is of great, help. And you have to be careful that sometimes some of those bridges can extend while manipulating the ICL. The only question I had, Rakshit, was how fast did the PCO fibrosis occur because of the optic capture and the bag being relatively empty?
So this was a very recent surgery. I've only done this. I've just seen the 2-week post-op 2 weeks ago. So it's just going to be a month now. So it remains to be seen how much the fibrosis, like you're mentioning, will happen. Hopefully it stays centered and stable.
Yeah, I'm sure it will remain centered and stable. Maybe some of these patients will need an early YAG cap because of the...
Absolutely. Their age as well, for sure.
The concept which has been introduced by David Chang almost 7 to 8 years back, and I think many of us are taking it up. I mean, ideally, the classical teaching was 3-piece lens goes into the bag and the rigid haptics act as a support for the capsular phonesis. But as far as the stability of the lens is concerned, especially if it's subluxated, creating an optic capture with the haptics in the sulcus obviously makes the bag a little more stable. And
Absolutely.
of course, as you mentioned, yeah, capsulotomy may be needed a little earlier.
Thank
But
you. Shall
still
go on
have
to
the advantage, the square edge of the capsule within the bag. It's only the haptics which is in the sulcus.
Yeah, we have many more speakers, so we'll shorten the discussion. We go on to our next speaker, Dr. Praveen Subudhi, who's a young consultant at Ruby Eye Hospital, Odisha, which was so beautifully brought together by his father, Dr. BNR Subudhi, and Dr. Praveen is taking it forward just the very right way. So on to you, Dr. Praveen. He's also the chairman scientific committee of the Odisha State Conference, so young guy taking his state to a higher level. On to you.
Can you see my video? It's in full screen.
Yes, yes.
So at the outset, thank you, Chitra Madam, and the team Eye Foundation for giving me this opportunity. So here I present a case. Sometimes mistakes do happen, and you have to deal with it. And it changes the course of events. Here the case of a dalk in an advanced keratoconus. I thought I did nicely, but overzealous removal of the stroma led to the perforation. So now I had to put a complete air fill with the corneal tissue, but after a few days, the patient presented me with like this. The patient had a large pupil and the pupil was not contracting and there was an intercapsular fibrosis. So I had to go for I don't have any option right now. I have to go for a cataract surgery. So the cataract was pretty easy. There was a soft nucleus and I need not use any phaco probe. I just need to use the IA probe to remove the whatever the lens and the cortical matter. And then I had to place the lens. After following the placing of the lens, now I had to deal with the iris. As you can see, it's a large iris. The iris is not constricting and the patient had bad vision. So now I had to go for single pass 4-throw pupiloplasty popularized by Dr. Amar Agarwal, and it's a very wonderful technique. So yeah, I'm using a 26 gauge needle to dock the tenoprolene needle. And once the pass is done, with the help of the micro forceps, I'm exteriorizing the loop. And then the 4 throws, the classic 4 throws. Then on tightening the either ends, the pupil starts constricting. So another single pass 4 throw in the superior part. Similarly, exteriorizing the loop. On tightening, the pupil starts constricting and you get a relatively mid-sized around 3.5 to 4 mm pupil. So the patient had photophobia before the surgery, and after the surgery, the patient was a little bit happy and had a pretty good vision. So I had promised this patient, if the patient is having a little bit poor vision, I would go for another 2 throws to make a pinpoint pupil to give more enhanced vision. So thank you for the kind opportunity.
Thank you, Praveen. That was a very interesting video. It takes it to a different approach now. So, Dr. Shreesh, I would ask you, how long would you actually like to wait before you do a cataract surgery? in these eyes from the primary corneal based procedure? And would it be different for DALC or would it be different for a PK?
The waiting for cataract surgery, if it is a very significant cataract and it is a mature cataract, you can go ahead and do it at any point of time after the initial DALC or PK. If it is like a total cataract, total intermittent cataract, you even have gone ahead with the cataract surgery within 6 weeks of the primary surgery. But ideally, you should wait for at least 9 months to 12 months when you remove all your sutures. And once the sutures are removed, you can plan your surgery and place a lens of patient's choice. Usually, these patients will have astigmatism. You can choose either a toric, customized toric, or a regular toric lens. So usually I wait for 9 to 12 months. Once all the sutures are removed, wait for 1 more month and then plan your cataract surgery.
Yeah, then what would be the other thing cost for the fixed dilated pupil?
A fixed dilated pupil, I think the patient must have had what is called the Uret's Zonular syndrome. He has placed a big air bubble and that must have gone behind the pupil and has increased the IOP, and the IOP must have caused ischemia of the dilator muscle, and so the pupil was fixed. And this must have happened. I think on the day of the surgery, in the night, definitely the patient must have had severe pain or the symptoms of raised IOP. And that could be the reason. Usually, these pupils, the iris will be very thin and it's very fragile. But of course, he could manage it very well. The pupil has almost become a round pupil, and it's of desired size, 3.5 millimeters. So he has managed it very well.
Thank you. So we go on to our next speaker. Thanks, Praveen. That was wonderful. We go on to our next speaker, Dr. Nikunj Kang, who's currently a consultant cornea and cataract services at SRJ Netralaya Indore, and a very dynamic surgeon. I've seen him during my ARC days, and I would unfailingly think that he's a treat to have in your list of surgeons showing their videos. So let's see what interesting thing he has to show now. On to you, Nikunj.
Thank you so much, ma'am. Thank you for that generous introduction. And it is always a pleasure and honor to be at this platform. So is my screen visible?
Yes.
Yes.
Yeah.
So I'll be sharing a case of a pediatric traumatic cataract where the child presented to me with a corneal rupture and iris tissue prolapse, which I only manage being the cornea surgeon here. And following which, after all the suture removals and waiting period of at least 2 months, he had developed a cataract. So this is the video of that cataract. So the title of the video is Two Rexes to a Toric IOL, and 1 second. The title of the video is Two Capsular Rexes Toric IOL and Two Pupiloplasty. So you can see in the picture that the child had a corneal scar in the area of the corneal repair and the few suture lines along that area. And the child presented to me after about 4 days of the injury, so that the iris tissue was already out of that corneal wound and we could not salvage that. And there is a large defect in iris in that area. And he had developed a posterior subcapsular cataract with a visual acuity of 6/36. And so I decided to do a cataract surgery with a toric monofocal IOL. As you can see in this IOL master, that he had significant about 2.9 diopter of astigmatism, and as it was a 5-year-old child, so decided to do undercorrection and targeted the refractive error of plus 2.5. The challenges with pediatric cases is, first of all, in anterior capsule handling, you need to be very gentle and you need to be understanding about the elasticity of these capsules, and your forces should be, centripetal. Use a forceps. I always prefer a forceps for making the capsular access in pediatric cases, especially. After the cataract was completely soft, and I just aspirated with the coaxial probe. As you can see, after removing that, there is a central plaque, which I tried to lift with the coaxial probe, but I was not able to do it. So I switched to coaxial illumination and then use the cystitome needle to gently lift off the plaque from the posterior capsule. And I was able to get a flap in that area, flap kind of elevation. Then using the forceps, I'm removing the plaque very carefully. The surgery was done quite slow. This is just edited version, so it is showing at a faster speed, and I was able to remove the plaque completely. Anyways, I was going to do a primary VCC, but you can see there is an oval opening while removing the plaque, which is made by mistake actually. And then I converted that oval opening into a circular primary posterior capsular axis of about around 4 millimeter in size. So in this case, I had to have a good circular capsular axis, anterior as well as posterior, as I was intending to implant a toric monofocal IOL in the back, and I was able to achieve that. In this case, I was definitely prepared with the multi-piece IOL or a three-piece IOL as a backup, but I could see that the capsular support was significantly strong anteriorly and posteriorly, so I decided to implant a monofocal toric IOL. Important thing is while you are injecting the oil, the haptic also has to go between the anterior and posterior capsule and go to the equator of the area, and then gently it has to be dialed, and then you can do the dialing of the desired axis. After making sure that there is no vitreous in the anterior chamber, using the tricoat which I use, which I'm not showing here just in the interest of time, I decided to reshape the pupil first by injecting pilocarpine. I'm bringing it down to its original undilated position. And now I'm taking a 10 of Rolling suture straight needle, passing it through the one end where the sphincter was damaged, and just at the end of where the sphincter was present in the patient, and taking the bite from the opposite end with the opposite sphincter where it was available. And then I'm doing a Sipser sliding knot here. You can do single pass 4 through also, but I'm trying to take the 3 passes first. As this is a pediatric case, I try to be extra careful, and I wanted to have a 2 knots or 3 knots at least. So after pulling the knot inside, I decided to bring the loop again out and pass 2 times, make 2 more loops, and then pull the knot again inside. So this is just a Sipser sliding knot. I have taken at least 3 knots over that, even though it makes the knot a little bit thicker, but it gives long-term stability. Similar way, I did another suture from the inferior area. And same way the suture was passed, I used the railroad technique to bring the needle out. And you can see at the end, the pupil is quite central. And important thing is here that both are the undilated state of pupil. This is on the left side, it is preoperatively, and this is postoperatively. So even though I'm not covered the area of the defect completely because there was actually genuine tissue loss, the pupil is a little bit lifted up because of redistribution of the forces around the sphincter, and it is bit centered over the cornea rather than preoperatively it was in the area of in the area of corneal scar of the corneal depth. The child is happy, and he is still undergoing amblyopia therapy. So thank you so much for this opportunity, ma'am.
Wonderful surgery. A lot of questions could be asked, although we still have 5 speakers here. One question I'm going to ask, Dr. Shail, Dr. Sandeep. What we want to know from Nikunj is, was the corneal astigmatism regular at all? How could you plan a toric IOL in that particular situation? And if he was going to do a pinhole pupiloplasty, then would that in itself negate the astigmatism to an extent? These are what we actually want clarity on.
I think first of all, Nikunj, excellent,
Excellent.
congratulations. Yeah.
Yeah.
So I think what ma'am brought out is correct. So we have published a series of toric IOLs in children, and generally literature suggests that this is a different case, traumatic, but generally by 5 to 7 years, the corneal astigmatism tends to stabilize, and then the astigmatism doesn't change very often. But like madam correctly brought out, if it's not a regular astigmatism, which it is likely to be irregular in such a case where there are scars and pulling of the cornea more in one direction, maybe, you can get away without a toric IOL as well, because if it's not regular, it's unlikely to be corrected by a toric IOL. So if the child cooperates, I think it's a good idea to do some form of anterior surface topography, could be pentacam or just a placido disc topography, to look for the regularity. And even if you don't have access to topography, you can just do an autoref and look at the Myers. And if the Myers are regular and circular, maybe you can consider a toric IOL as well.
Yes, Dr. Sandeep? Unmute yourself.
see, if there's a high amount of astigmatism, which very often is the matter with these irregular corneas, sometimes I've found that there is some component of that. You can see in the what are those images like Zernike? You have another thing in the topographer. What is that image? Just the name, a thought block right now. There is something where you can find out how much is the amount of regular astigmatism there. And that portion can be corrected because that can probably reduce the load of the refractor. Can anyone remember the name? Just like we have Zernike, we have something else which is there in our topography. So it gives us some amount of that. So you can probably correct it. But this point, madam, that you made about pinhole pupiloplasty, whatever you do, you can't exactly make it like a pinhole. So I don't think you will have the refractive error or the astigmatic portion completely corrected. Yes, it may give you better quality of vision in terms of reduction of glare, but you can't really achieve the pinhole that a pinhole actually gives when you place it in your spectacle frame. So yes, that's the other comment that I'd like to make.
Okay. Anything you want to ask, Tamil, before we go on to our next speaker? It's a very interesting case which he has presented. A lot of questions could be asked.
Very nice video, ma'am. I think all the points are discussed. So we'll move on to the next one.
Yeah. The IOL power calculation formula is one thing, and one other thing which could have been asked. Dr. Nitin, you have anything to add till when I ask our next speaker?
So basically, in this case, with the amount of irregular astigmatism which could be present, I think I would be a little cautious putting in a toric IOL because that is one thing. And the second thing is we have done quite a few cases of keratoconus with where we've been able to not correct the astigmatism, but correct the quality of vision with a fourth row single pass fourth row pupiloplasty. Obviously, like Sandeep said, it is not a typical pinhole, but reducing the size of the pupil to a fairly small extent definitely improves the quality of vision. And it also improves the quantity of vision. So both quantitatively and qualitatively, the patient is much better off. So if anyway you had planned, if I had planned to do a pupiloplasty, I would have reconsidered whether I want to put in a toric IOL in this case. But it was a brilliantly done surgery. There's no doubt about that.
Yeah. So we go on to our next two speakers now, Zain and Ankit, both are pediatric cataracts. So Zain and next to Aniket, and please all of you all mute your background noise, please, because I can hear the
another 100 years.
So, Zain,
Yes, ma'am.
who is talking now? I don't understand now. One of our, please. Dr. Zain Khatib is a cataract refractive and glaucoma surgeon from Khatib Eye Clinic, Mumbai, and again doing a lot of work along with the Yossi Dynamic Association. So yes, on to you, Zain. Let's see your interesting video. And
yes.
Zain, we will have Aniket presenting his.
Yes, ma'am, my screen is visible.
Yes.
Yeah, so this was a uveitic cataract 80-year-old lady who had first eye cataract surgery done many years back, and now she's presented for the second eye. So we just have to go in a stepwise approach in this case. We are making the ports, and then with a Y hook, I'm just separating out these posterior synechiae. And this is not very difficult. They're not very adherent. And then, injecting viscoelastic is important. And then taking two Y hooks, I'm doing a very gentle stretch pupiloplasty here. Not very traumatic, but a small. And then now the, eye is good enough to put in a B-hex ring once you do stretch pupiloplasty. And B-hex ring goes in very easily. So, again, the misconception that B-hex can't be used in these kind of pupils is wrong. You can do it once you do it like this. And this also is a very hard cataract. So we require good, pupillary dilatation for the surgery. Now, the other challenge is to put in dye after viscoelastic. So we have to really paint the dye on the anterior capsule. It doesn't get properly stained, but then this is good enough, once you do a painting. And now I'm doing the capsular excess with a Haldipurkar forceps. Now, while doing the capsular excess, I'm not encountering much problem. So the zonules seem quite okay at this stage.
And then I go ahead and do a gentle hydrodissection here. Yes, and now the nucleus is freely rotating, and I proceed with doing a direct vertical chop. So this is a vertical chop that I'm doing, direct chop, and this is my preferred approach in case of hard cataracts. And here we can see that there's a leathery posterior plate, so lateral separation has to be, a bit strong. So I've broken the nucleus into about 6 segments, and then each segment is got to the iris plane, and it is emulsified. So, so this is the surgery going on at 4 times the actual thing, and quite routine. The phacoemulsification, although the cataract was hard, is quite routine. But as soon as I finish phaco and come out, the first thing I notice is that that inferior capsular excess margin has come slightly inside. So I'm a bit wary. I feel that there may have been some zonular dialysis during the phaco or pre-existing. And while removing cortex, this thought gets confirmed because you can see that the cortex is really adherent to the capsule, and there is definite posterior zonular laxity. Posterior zonular laxity is definitely there in all quadrants, and inferiorly there may be some dialysis that may have been caused. You can see how the rhexis margin was not so inside, and those small fragments going behind which are moving, that itself also suggests that there is some posterior zonular laxity. You can see there as well while picking it. So now the next step would be to put in a CTR. And again, CTR, I have this preferred way where I use my blunt chopper in one hand to make sure that it doesn't stretch the anterior capsule too much while it is being inserted. And then with the other hand, I take a Sinskey hook to ensure that it goes into the bag. And the IOL then is inserted into the bag. You can see while putting the IOL also, there's a lot of positive pressure coming from behind, so yeah, so that completes the case, and then I remove the B-hex ring under irrigation always. This is one of the easiest pupil expansion devices to remove from the eye. You just remove all the 3 flanges, and then that is done. And after removing the viscoelastic from behind the IOL, that completes the surgery. So basically, this surgery was just to show that a cataract surgery, which is difficult, if you just follow the right steps, you can achieve a good result. You have to go in a systematic way. Thank you.
Wonderful, wonderful, Zain. So many wonderful tips. We will come back to your discussion. After we hear Dr. Aniket also. Sorry, Aniket. I was too engrossed in your surgery. Dr. Aniket is a cataract, refractive, and medical retina surgeon. Is practicing at his eye clinic at Prayagraj at Uttar Pradesh. Again, a very confident, self-evolved surgeon. And I have watched him with pride during my ARC term as to how well he has got himself, known, very well known in the different segments of our country. So on to your video, Aniket.
Thank you, ma'am, for such a kind introduction. Is the video visible?
Not yet. Yeah.
Okay. So the topic is small pupil hypermature cataract, similar to what Dr. Zain showed just now. So this was a patient of uveitis, about 75 years old female patient having uveitis since many years. We have controlled her anti-uveitis with topical steroids, and it's been 3 months since there has been no AC reaction, and now we have gone for cataract surgery now. So we can see there are some posterior synechiae and irregularity of the pupil present. So in this case, again, anterior capsule is stained, and the AC is washed. And now I'm putting some intracameral adrenaline to dilate the pupil. The pupil is not getting dilated beyond this point. So under high density viscoelastic, that is sodium hyaluronate 1.4%, I'll just insert my pupil expander device. The device which I prefer is Gupta ring, that is a 4-flange pupil device, and we can use it insert it using IOL injector, like any normal Indian IOL injector can be used. and easy to insert. Once it's in the AC, we have to fix the 4 flanges to the pupillary margins. No special instruments are required. We can see that the AC is a bit shallow, so I have to keep putting in the viscoelastic here. Once the expander is in place, now we have an ample space to do capsulorhexis. Now this is the hyper mature intumescent cataract. So I won't be doing the whole rhexis with my needle. I will switch to the faucets and make a small rhexis first. This is to prevent rhexis run out. Now, using irrigation aspiration, I'll remove the excess cortical matter. This will reduce the intraventricular pressure and allow me to extend the rhexis further at a later stage. During this maneuver, I tap and rotate the nucleus so that the excess cortical matter behind the nucleus also comes out. Now, using micro excess faucets and scissors, I will increase the rhexis size. Now I have achieved my desired rhexis size of approximately 6 mm. The method I prefer is usually stop and chop, and this was not a very hard cataract, must be grade 3+. So using stop and chop method, this is a 4x series, so many details are missed here. But after this, just irrigation aspiration is done to remove the adherent cortex. You can see that the cortical matter is very much adherent to the capsule. After removing the cortical matter, I'll just fill the AC with viscoelastic and insert the IOL. The single piece IOL in the back. Now in the same maneuver, I can remove the expander from the AC. During this maneuver, it is important that I keep one instrument above the IOL expander below the corneal to prevent touch to the endothelium and damage to it. Removing the viscoelastic from AC. Now, since it was a case of uveitis, to prevent post-operative excess inflammation and resulting in lower vision, I'll just give IVTA. Now the case is done. The patient had good post-operative vision with relatively less inflammation and was very happy.
Wonderful videos. Both the videos were just one to beat the other. And Tamil, can you take the first question with our expert panel?
Yes,
We
ma'am.
have 3 more speakers, so we'll have to be.
Yeah, Dr. Like we have discussed about the rigid pupil and elastic pupil, whereas the pupil in a uveitic cataract is totally different. Sometimes the tissue is friable and it can tear off. So how do you approach small pupil in a uveitic cataract?
Whom are you asking?
Dr. Ramamurthy, sir.
Yes.
Well, I think both the surgeries were very well done and with excellent results. I mean, as far as be as gentle as possible, and as was mentioned by Aniket, always wait for the inflammation to subside. And I always make it a point to inject an air bubble immediately after I make an incisions. Even before injecting any viscoelastic, I inject an large air bubble. Go with an iris spatula and break up the posterior synechiae all 360 degrees. Once I do that, and if there is any membrane there, if you peel that off, then if you use high molecular weight viscoelastic, most often I find that you get enough dilatation not to resort to any of these devices. And then subsequently, of course, you do an adequate size capsular excess and proceed with the rest of the surgery. Even though you might get total cataracts in these cases, these cataracts are usually quite soft or at least quite brittle, so that chopping or aspirating them is quite easy. So the results are reasonably good. And of course, injecting a steroid at the end of the surgery, especially if there's recent history of inflammation, is a good idea. I think Shail's group have published using depot steroids in these cases. Maybe you can comment on that.
Yes, Shail?
Yes, ma'am. So we come did a randomized trial comparing in doing cataract surgery along with Ozurdex implantation and non-Ozurdex, and we found that the recovery and the inflammation and CME rates were much less when these eyes were treated with Ozurdex along with cataract surgery. But I think it's something which we can choose on a case-to-case basis. If the eye has been quiet for a very long time, and with the good cataract surgery, maneuvering and good topical post-operative medications, most things can be handled without, use of intravitreal injections. But yes, in a very chronic situation, they do tend to help in at least a good and faster recovery.
Do you have any specific indication, Shail, as to when you would?
So typically, sir, particularly these kinds of the first case with the completely bound down pupil, 360-degree synechia, iris bombay, already cornea also showing changes of chronic uveitis. Even though there may not be active inflammation in such eyes, these are some of the eyes where we would strongly consider combining cataract surgery with Ozurdex.
Now, when I know we have to go on to Dr. Sameer now, with this posterior zonular weakness, would it make sense to place a CTR first or to place a CTR later? Any of you would answer?
Same day can place it as late as possible and as
we
a,
have stripping. What? No, stripping the cortex becomes a bigger challenge when the posterior zonules are quite weak. So, but that is something only when you start stripping, you realize it, no? So by the time you would have already inserted your CTR, right? So, is there?
I think in Zen's case, there was a little bit of fluid misdirection because you could see that maybe the zonules were weak, but they were also allowing egress of fluid into the Burgess space. And I think his posterior capsule was looking a little convex. See that material over there. So
that could have also been the issue which was causing more difficulty. Yes, very true. Very valid point. Yes, I had a similar case last theater, and it never struck me that I could have had a fluid misdirection then. Good. So we go on to our next speaker, Dr. Sameer Chaudhary, who's a medical consultant at Arvind Eye Care Hospitals at Madurai, and a genuinely great human being. And I think he has the entire batch of the young fellows and the younger doctors together with him and going strong in the Madurai Center, and quite a leader in himself. So on to you, Sameer. Let's hear your interesting presentation.
Thank you so much, ma'am, for the kind introduction and the opportunity. So I'll be presenting a case of Toric IOL where the implantation had resulted in a rent and how it was further managed. Let's see a case where implantation of a toric lens resulted in a PCR and was managed further. After manually marking the axis of the implantation and the incision, keratome and side port entry was done. The grade of the cataract was nuclear sclerosis 2 and was emulsified using modified CHOP technique. This was followed by cortex wash using a coaxial probe and was concluded uneventfully. A cohesive viscoelastic was injected and the bag formed well without any sign of a PCR. Preloaded acrylic toric was injected into the bag, and as the IOL unfolded, a jerky movement with a Sinskey's hook decentered the IOL. The IOL was found to be tilted, and a peripheral posterior capsular rent was noted. The IOL was dialed into the anterior chamber, and a spatula was used to check for any vitreous disturbance, which was absent at this moment. So what's next? Either we leave the foldable IOL in the bag if the rent is small, or explant in exchange with a multi-piece lens for in-sulcus implantation. As the PCR was in the axis of implantation, a decision to explant the toric IOL was made. The main corneal incision was extended and intracameral lignocaine was injected. At this stage, a dispersive viscoelastic was used to coat the PCR to prevent vitreous prolapse and to protect the endothelium. A multi-piece foldable acrylic IOL was implanted into the sulcus to act as a scaffold and protect the posterior capsule during the Toric IOL explantation. The IOL was attempted to explant following the Pacman technique using a Donenfeld microlens holding forceps and Osher IOL cutting scissors. However, this was met with a lot of difficulty and resulted in the damage of the corneal tunnel lip and caused iris prolapse. Ultimately, the haptic was exteriorized using a spatula and a Sinskey hook and dialed out of the eye using two McPherson forceps. The explantation of the IOL in this case was arduous due to the presence of a posterior capsular wound. The PC was protected further by the implantation of another lens. The Pac-Man technique, named after the video game, when followed correctly, makes IOL explantation a safe and relatively easy surgical step. This involves dialing the haptic towards the main port and cutting the 2/3 of the optic from the optic-haptic junction, leaving a small hinge distal. It is at this hinge the mouth of the cut IOL opens as it is dialed out in an anti-clockwise direction using a McPherson's forceps, effectively decreasing its overall diameter. After such significant manipulation, vitreous prolapse into the anterior chamber was noted. The corneal tunnel was closed using a cross suture and a single interrupted suture to ensure that the globe stays formed. And automated vitrectomy was done along with an AC maintainer. Intracameral pilocarpine was injected to constrict the pupil and note any peaking. While hydrating the side pore, a vitreous stand was found peaking the pupil, and again, automated vitrectomy was done. And the case was closed. Thank you.
Thank you. Thank you, Dr. Samir. Yes, Dr. Nitin is there? Dr. Nitin, are you there?
Yeah, I'm there.
So in this particular case, I'm sure, I think, he could have done without enlarging the incision, right? Because anyway, it's going to cut the IOL. And if the iris prolapse starts happening, then, it becomes quite messy. That was one thought of mine. But would you have done an optic capture or a reverse optic capture in this particular case of, and still done?
The main thing is it was a toric IOL and the axis and the PCR was in the axis of the intended cylindrical axis. So in such a case, to get a lens, even to do an optic capture would have been a little challenging. And I think what he did was the right thing. The only thing different which I would have done probably is, like you suggested, to have the IOL split into two pieces and get it out. It would have been much simpler, especially since the posterior capsule was already supported by the 3-piece IOL, which was put in.
Yeah.
Ma'am, actually the multi-piece IOL, so we usually inject with a B cartridge. So that actually requires a 3 mm incision. So the initial incision was smaller. So to insert that multi-piece IOL, I had to extend the incision a bit.
Yeah, yes, I agree. Kamal, you have any question?
The only point I would like to make, Samir, is it was obviously a brilliant surgery, but then in such cases, I would like to inject the multi-piece IOL with a sensor cartridge, because if you use it with a sensor cartridge, it can go in with through a 2.8 millimeter incision without a problem. I agree that the B cartridge definitely requires a much larger incision, but then you could have prevented increasing it. But just the point, means obviously it all depends upon having that cartridge with you in the OT at that time. But that's just a thought which I had in my mind.
Yeah, yes, Tamil?
Yes, ma'am. Always, when we are cutting the IOL, the cutter always it is bulky, and sometimes the iris starts prolapsing from the tunnel. I just want to know from the panel, has anyone used the IOL cutter device by Dr. Neha and your experience? Anyone from the panel?
Dr. Sandeep?
I was supposed to use it in one patient, but somehow there was a problem because it was for the first time she had made one for the Centurion machine. And the problem there was that I was not able to get the sleeve back to expose the jaws of the blade. So she needed to make a larger one. So I couldn't use it in that patient. But I guess it is good. I've seen some videos of it being used, and I think it's a very good device. In fact, we are making a new one now for that. Because, for every different handpiece and for every different sleeve, there has to be a different size. It can't be one size fits all. So that was the challenge we had faced when we had attempted.
Yes, nice. So we go on to our next speaker, Dr. Anujit Paul, who's a young cataract and vitreoretina surgeon from BBI Foundation, Kolkata. And it is such a moment of pride to see Anujit doing so well in his career, because I was always, a great friend of Ajay Paul, and I was always used to admire his great skill. And it has just completely flown into Anujit. I mean, the genetic transfer has been just complete. So on to you, Anujit. Let's see your magic.
Thank you. Thank you so much, ma'am, and thank you for the opportunity. So I would be presenting a case of a developmental cataract in a 25-year-old female patient. So in these cases, usually on slit lamp examination, it's quite difficult to understand what's happening. So at this stage over here, I'm not really aware of how much of nucleus and how much of cortical matter I have to deal with. So this is quite similar to Dr. Karan's presentation as well, where the anterior capsule is slightly fibrosed. It's not possible to understand what's going on. So with the fibrosis, I shift to a forceps maneuver. And once the anterior capsule is removed, I get a better idea about what's going on. On hydrodissection, there is a lot of loose cortex that is there. And just with the irrigation and aspiration cannula, I'm just trying to remove a bit of loose cortex, which is there. This was one of the first cases of developmental cataracts that I did. So I was going in blind, unable to expect what was going on. The posterior capsule seems intact, and with a healthy rhexis, once I got the loose cortical matter out, I can see that there is loose cortex, which I'm aspirating with the phaco tip. And there is this large plaque, which I don't know what to do with. So the actual challenge for me is over here. What do I do? How do I remove such a large plaque? So what remains is this huge thing, which I'm trying to just maneuver with the IA probe, and it's too difficult. So I go ahead and implant a 3-piece IOL in the sulcus, dialing the multi-piece in. I decide now that entire eye seems to be more stable, and with a 23 gauge vitrector, I'm trying to make some dent into the hard material of the plaque. Once again, this is slightly more thicker than the ones that were shown in the previous videos. And even with quite a bit of pressure, you can see my cut rate is around 3000, which is the maximum for Centurion. I'm not being able to make a dent anyway. So I'm trying to reduce the cut rate over here to 2000. And in these cases, I would like a word from the panel as well, what they would do in such a case over here. Even though I managed to separate one edge over here, now two edges, and now the superior edge over here, it still seems to be quite adherent to the remaining portion. So finally, with most of it separated and being attached at one point, I'm just trying to manually remove the plaque with the help of a cannula and expulse it into the anterior chamber. After that, it's quite easy, and with the help of a non-tooth forceps with a slight tug, I can remove the entire posterior plaque. So I continue anterior vitrectomy once the plaque is removed, and over here I will be using triamcinolone assisted vitrectomy as well. And once I secure the visual axis, make sure the visual axis is cleared, I put the lens back into position, and ultimately in this case I end up with a clear visual axis and a round pupil.
Very well done surgery, Anujit, extremely well done. So Shail, what would you have done differently here, or anything to add?
I think excellent. Congratulations, Anujit, on an excellent video. Such plaques are impossible to cut with vitrectors or anything. So I would have probably used a 26 gauge needle, try and create an opening outside the area of the plaque, and then try and use the rhexis forceps to try and encompass that plaque and create a PCC, very large PCCC. But I do acknowledge that that would still not have been possible. And then probably from multiple side ports, you would need the vitreoretinal scissors to cut the plaque as much as possible and create a clear visual axis. The only thing I would have done differently is I would not have placed the IOL until the posterior capsule has been handled, because anyway, with such a plaque and with such a large PCCC, you would more than likely to place the three-piece in the sulcus and capture it through the anterior capsular axis. So probably IOL could have been injected at a later stage as well.
Yes, yes. Anybody in the expert want to add anything? Yes, Shri?
Yeah,
Yeah.
Yeah.
Okay, sir. Go ahead, please. Go ahead.
Okay, I agree with Michelle regarding the placement of the lens. One additional point I want to say, when we encounter this situation where we find it very difficult to make the anterior capsular axis, you can use the vitrector there itself, sometimes when there's a lot of fibrosis and you can't really complete the rexus, you can use the vitrector with a high cut rate and low vacuum, you are able to complete the rexus. So that's one additional point I thought I share with the juniors. It's possible to do that.
Yeah. Yes, Trish?
It's a nice case, a very difficult case. He has handled it very well. I would have done the same way, the anterior capsular axis and then cataract extraction. The posterior capsule, it is very thick and fibrous. I would have gone ahead with the MER knife from the side port behind the eye hole and made a nick in the posterior capsule. It penetrates through the thick capsule. Then you can insert your vitrector cutter and you can chew it out. So it would have made a round rexis kind of thing in the posterior capsule. I would have tried that.
Yeah. Good. Thanks a lot, Anuji. We go on to our last speaker, and a very patient speaker. I think even before she starts her talk, we should give her a clap for waiting so long to give her talk. So it's Dr. Gunjan Budhiraja, and she's working as a cataract, cornea, and refractive surgeon at I7 Eye Hospital, Lajpat Nagar, New Delhi. So on to you, Dr. Gunjan.
Yeah, thank you so much, ma'am. And thank you for all the panelists also for hanging out for such a long time. So I'm going to share my video soon. Is it visible, ma'am?
Yes.
So just start the
So,
video.
phacoemulsification of cataract in coloboma, presented by Dr. Gunjan Budhiraja.
I'll just cut it.
Application. A main incision is created to achieve adequate pupillary dilatation. Iris hooks are inserted. Capsular axis is started here, but in the initial time, we face little difficulty due to the elasticity of the capsule as well as weaker zonules. In spite of being careful, the capsular axis tries to run out in the periphery, so a visco is inserted inside the eye with the same cannula. We are able to save the rexus for a safe phacoemulsification, and a round regular rexus is created here. Hydrodissection and hydrodelineation is done with successful rotation of the nucleus inside the bag. Phacoemulsification is started with stop and chop technique. After achieving an adequate depth, the nucleus is tried to crack. We do not achieve a full crack in the nucleus, some fibers being attached in the posterior plate, so we convert the case into a direct chop. In flower petal manner, the nucleus is tried for separation, but still we are not able to achieve a full crack. Subsequently, we tried to track the nucleus again and again, and finally, we achieved a full crack. One fragment is emulsified, and the subsequent removal of all the fragments is done here. Slowly and gradually, all the fragments are separated from the posterior plate. Carefully. Finally, we are able to achieve the emulsification of all the nuclear fragments. The residual cortical matter is removed by coaxial manner. Posterior chamber IOL is inserted inside the bag. The iris hooks are gently removed from the eye, and a viscoelastic removal is done. We can see a clear cornea at the end of the surgery. Thank you for watching the video.
Oh, that was a wonderful presentation, Dr. Gunjan, because it's quite a challenging case in a small eye, and these cataracts are more often than not, they are dense cataracts. So she's done well. Only thing is, if you had stained with Trifan blue, maybe first you should inject viscoelastic and seal that area of zonular, that iris coloboma area, so that there's no fluid misdirection. And then you have to paint the Trifan blue and then making rexes, because you really need a rexes to be complete here, because you would quite likely need a CTR in many of these eyes. So that could have been one thing which could have done. Tamil, can you ask some questions?
Sorry, ma'am. This is a very old video. Like
Yeah.
when I was,
Yeah.
I prefer to be very safe than just
Yes.
that.
A great video, Dr. Gunjan. And do you prefer to do superior phaco in all your cases, or you chose to do in this case?
No, I chose to do this in this case because my retina colleague was also going to operate on the patient. So he said that he has to put some trocars near the time. So usually I do temporals, but yeah, not always. I look at the keratometries also because then only I decide the specific incision sites.
Okay.
Any other question, Tamil?
Dr. Sandeep sir, if there is a microcornea, how would you approach?
Well, microcornea, see, first of all, the question is whether I would be putting an IOL in these patients, because it's very difficult to put an IOL there. In case the plan is not to put an IOL, then achieve as good an aphakia as possible.
Yeah.
But I don't know if the panel has some experience. Shahid, do you have any experience of putting an IOL in a microcornea?
I think anything less than 9 millimeters. I think even though we may heroically put it, the eyes end up being
Yes.
disastrous with the glaucoma and other things, developing inflammation and glaucoma. So I think good aphakia and aphakic glasses are also not a bad option, because these patients are anyway so handicapped that for them
Right.
that itself is good enough.
And many of these microcorneas are highly myopic as well. So I've never really had the. I've done 2 of these patients and I've left them both aphakic, if I remember. Yeah.
Absolutely,
Yes.
sir.
Yes, Dr. Nitin, Srish, one word from each.
Yeah, I agree with you. I would have also stained the anterior capsule for sure in such cases, because that is very important, paramount to see to it that you get a complete rexus, and to also know where your rexus margin is. The most important thing in these cases is that there could always be a zonular weakness in the area of the coloboma. So
Yeah.
one thing which I would have definitely done is every time I come out with an instrument, even if I don't have an obvious zonular dialysis, I would keep, before coming out with the irrigation, I would keep injecting viscoelastic into the chamber to fill in the bag again, so that in case there is a zonular dialysis which has not been seen, at least you would be protecting that. Otherwise, it was a very well done surgery.
Yes, Dr. Ramurthy, you have anything to tell?
Yeah, no, very well done surgery. Just a comment about the lens choice. What has been recommended is also you can, in extreme microcornea, is to cut off the haptics and just put the optic alone. Sometimes in a small capsular, small like the small capsular bag, that also fits. Otherwise, very nice session, very well done.
Yeah, Shrish?
No, like few points. It's very well done surgery. And I slightly decenter the rexis. Usually, I move slightly away from the site of this the defect. And here, of course, there was no defect. The lens was intact, and there was no lenticular coloboma. And I would have definitely stained the anterior capsule or painted the anterior capsule, and I would have sat on the temporal side because you're 90 degrees away from the direction of weak zonules.
Yeah.
So otherwise, and again, the small eye, there's microcornea. Anything less than 10, it is very difficult. 10 millimeters of white to white. If it is more than 10 millimeters, 11 millimeters, you can go ahead, and we even have cut the tip of the haptic and placed the lens in the bag. And Alcon manufactures small lenses like 11 millimeter, 12 millimeter lenses. We can inject those lenses in these cases.
Oh, good. So I think we have come to the end of this very wonderful series. I mean, it just goes without even everybody would clap together for such wonderful set of videos. I think we never realized that 6:30 started and it's going to be 10 minutes to 9. And there has been so much of learning from each of these videos. Each of these videos have been so beautifully tailored and put together. I mean, it was so flawless and there was so information. Right from the way you remove the iris capsule hooks from the main port, and it's one of our beginning surgeon when Nilesh did it. So from there on, there was series of learnings from all of you young surgeons, and really look forward to many more continued associations with all of you. I think whoever has watched these videos or who is going to watch later is definitely going to be very enriched. And thank you so much, expert panel. I don't believe that I could have got a better expert panel than you for this lovely set of videos. You all really did justice and gave just the exact learning tip which each of our questions wanted. Thank you all. Do go back to the nice dinner and happy memories of an Eyeedu webinar with us. Thank you.
Thank you. Thank you, Chitra.
Thank you. Thank you so much, Chitra. Thank you, everybody.
Thank you, everybody.
Thank you.
Thank you, everyone. Good night. Thank you.
Good night. Thank you.
Thank you.
Thank you.